Hey everyone, thanks for joining. Today we're going to tackle one of the most common heart rhythm problems out there, atrial fibrillation, or AF for short. Our goal here is to really cut through the noise, break down what it is, why it's a big deal, and how doctors are managing it. So let's just dive right in. So, what is atrial fibrillation, really? Well, in the simplest terms, it's when the top two chambers of your heart, the atria, just stop beating like they're supposed to. Instead of a nice, steady pump, they just sort of quiver. You can think of it as electrical chaos breaking out in the top of the heart, which leads to a heartbeat that's irregular and, a lot of the time, way too fast. And, this is not some rare, obscure condition, not at all. In fact, your risk of developing AFib literally doubles with every single decade of your life. And that right there is why understanding this is so important, whether you're thinking about your own health or the health of someone you love. Okay, so here's how we're going to break it all down today. First, we'll get into what this irregular rhythm is all about. Then we'll look at who's at risk and how it gets diagnosed. After that, we'll cover the two main goals of treatment, and we'll wrap up by talking about what it actually means to live with atrial fibrillation. All right, let's jump into section 1, the heart's irregular rhythm. So, what's the big deal about a little flutter in the chest? Well, as it turns out, the consequences can be pretty serious. And here's the absolute number one reason why it matters. When the atria are just quivering instead of pumping properly, blood can get left behind. It pools, it gets stagnant, and it can form clots. Now, if a little piece of that clot breaks off and travels through your bloodstream, it can get stuck and block an artery. And the most dangerous place for that to happen? The brain. That causes an ischemic stroke. But those clots can also go to other places, like your legs or even the arteries that supply your gut. So that's pretty serious stuff, which leads to the next logical question: who is most likely to develop AF in the first place? Risk factors for AFib really fall into two different buckets. Over on the right, you've got the stuff we just can't change. Getting older, our genetics. But look at that list on the left. That's where we have some power. This is the stuff we can influence. Things like managing blood pressure, maintaining a healthy weight, and making choices about smoking and alcohol. It shows there's a real opportunity to be proactive here. Okay, so we know what it is, and we know who's at risk. But how do you actually find out if you have it? Let's talk about the symptoms and the path to getting a diagnosis. And this, right here, is one of the biggest challenges with AF. A full 35%, more than a third, of people with this condition are completely asymptomatic. They feel nothing, zero. For the people who do feel symptoms, it's often palpitations or just feeling really tired. But it's that huge asymptomatic group that really shows why checking in on your heart health, even when you feel fine, can be so crucial. Now, the good news is the path to diagnosis is actually pretty straightforward. It can start with something as simple as a doctor checking your pulse. The classic sign of AF is what they call an irregularly irregular pulse. That means it has absolutely no pattern. It's just random. And if they find that, the final confirmation comes from a 12-lead ECG, which gives this really detailed map of the heart's electrical signals. Right, so once AFib is diagnosed, the treatment plan kicks in. And it's really a two-pronged attack. The first goal is all about getting the heart itself under control. And you do that by managing either its rate, how fast it's beating, or its rhythm, how steady it's beating. So doctors have two main strategies to choose from. On one hand, there's rate control. The goal here is pretty simple. Just slow the heart down to a safer speed, even if the rhythm itself is still a bit chaotic. On the other hand, you've got rhythm control, which is a bit more ambitious. That's where you try to restore the heart's normal, steady beat, what's called sinus rhythm. Which strategy is best? It really depends on the individual person. Now, to get this control, doctors have a few different tools in their toolbox. For rate control, they often turn to things like beta blockers or calcium channel blockers. You can think of these as gently pressing the brakes on a heart that's going too fast. For that more ambitious goal of rhythm control, they might use more specialized medications like amiodarone to try and actually reset the heart's electrical wiring. But listen, controlling the heart's rate or rhythm is only half the story. It's a huge part of it, but we still have to deal with the single biggest danger we talked about at the very beginning, that risk of a stroke. So this really is the million-dollar question, isn't it? How do doctors figure out who needs powerful treatment to prevent clots and who might not? How do they make that call? Well, they use this very clever tool with a mouthful of a name, the CHADS-2VA-ESC score. Now, I know it looks complicated, but don't let the name scare you. It's just a point system. Doctors go down this checklist, they add up the points based on a person's individual risk factors, and that final score tells them just how high that stroke risk is. As a rule of thumb, a score of 2 or more almost always means it's time to start a blood thinner. But of course, it's never quite that simple, is it? Because the very medications that prevent clots, the anticoagulants, they also, by their very nature, increase the risk of bleeding. So you're always playing this balancing act between benefit and risk. And guess what? There's a scoring system for that too. This one, called the Orbit score, helps doctors get a clear, formal picture of a person's bleeding risk. So by comparing the two scores, stroke risk versus bleeding risk, the doctor and the patient can look at the numbers and make a really informed decision together. Now, the really great news is that modern medicine has made this whole balancing act much, much safer and easier. The newest drugs, called direct oral anticoagulants, or DOACs, are now the go-to choice. They're way more predictable than the old standby warfarin. And for patients, this is a game changer. It means no more constant blood tests and clinic visits, which is just a huge step forward in quality of life. Okay, so we've covered a lot of ground. When you put all of this together, what's the big takeaway? What does it really mean to live well with a condition like atrial fibrillation? I think this quote just hits the nail on the head. Yes, AFib is absolutely a serious condition. You have to respect that stroke risk. But with the right diagnosis, a clear understanding of the risks, and these incredible modern treatments, it is absolutely a manageable one. The real goal is to move from a place of fear to a place of understanding and empowerment. So I'll leave you with this final thought. Now that you have a better grasp of AF, the risks, the solutions, what's one conversation this new knowledge could spark for you? Maybe it's talking to your doctor about your own risks. Maybe it's encouraging a parent or a friend to get their pulse checked. Knowledge is the first, most powerful step toward taking control. Thanks so much for joining us.